Okay, so thank you, Double Manus, for the invitation. And please, I will ask the audience to forgive me because I recently moved from Pascal Boileau's unit to another hospital, so I will not present to you today some good series as everybody knows the result of Pascal Boileau. I prefer to show you how I'm thinking about lateralization in the glenoid, just to have a way of thinking and maybe to open the debate. So a little bit of background to start. The concept of reverse prosthesis is a biomechanical concept that associates the medialization of the center of rotation and the fact of lowering the humerus. This was well described by many authors, Boileau and others, and you have many papers about the subject. Why do we try to do this? Just to have a better deltoid tension to avoid cuff wear. And the first goal, I think that everybody agrees here, is to restore the active and anterior elevation. So what are the advantages of a Gramon's design? You have normally a better run of motion in elevation. You have a better deltoid strength. You have a better stability. When we compare the small heads that were the gold standard in the starting of the experience of a reverse prosthesis, and now we have bigger heads. And also we have less component stress. But we have some problems that remain with Gramont design. We have scapular notching, that was well described by many authors. We have limitation in the rotations. Sometimes when the cuff is torn and when the deltoid is not at a good tension, we have instability, and we have also poor shoulder contour in some of the prosthesis design. So a good solution may be the lateralization. Lateralization with the implants or with the bone. With the implants, Mr. Frankel made a study. I'm sorry I didn't put the reference but on the topic, but he said that you have better rotation but a lack of elevation. I think all the prosthetists with, who lateralize in the base plate don't have this problem, but I don't have big experience about that. I just talk about that with Jean Cani some days ago. And this type of prosthesis also have some constraints on the glenoid side due to the lateralization on the implant and the center of rotation, which is not at the junction between the base plate and the bone, but inside the implant. I think that bony lateralization have less constraints on the implants, maybe a significant reduction of scapular notching, even better than the lateralization in the implants, and more natural shoulder contour, the same as the prosthetic lateralization, in fact. And for both of these implants, we have less instability because of a better tension of the muscles. So, how I'm thinking about it? Let's try it. So let's plan it. I use blueprints from initially Tournier, then Wright, and now Stryker. It's one of my cases in my new hospital. It's a 63 years old woman, active retiree. She comes to my clinics with two symptoms, pain and a pseudoparalytic shoulder. But look at the rotation, external and internal rotation. She has quite good rotations. So the problem in these patients is to give them back the anterior elevation, but to keep the rotations. We can see on the CT scan that she's AMADA 2, she has a B1 glenoid, and she has a supra and infra spinatus steer with a fatty infiltration that don't allow us to make a repair. For all the case I have planned for the topic, I use exactly the same humeral planification. I lower a little bit the humerus, but I don't lateralize the humerus. I think that Philippe Barante will explain that better than me in a few minutes. So I try with the classic one configuration, a classic base plate, classic head, and the configuration of the humerus I showed you before. We can see that we have poor adduction, we have quite good rotation, and we have flexion, which is not so bad, but not so good also. Then, first trial to have a little bit more lateralization and to avoid scapular notching. The eccentric one, we can see that we have not so much more AD deduction, the rotation seems to be a little bit better, but the flexion doesn't move. So I tried to do the BioRSA, but sorry again, but you can do a bio, you can do exactly the same with the implants. Okay, the bio is just because I use it on the plan, but you can do exactly the same planification in the same way with the implants. In this case, we see that we have a better AD deduction, better AB deduction, better rotations, and better flexion. But as I used to do with Pascal Boileau, I also try the asymmetric BioRSA to see if it's better like this. And when we compare all of these four planification, what we can assess that the poorest one is the classic configuration, which is quite good, but we can do better, I think. And I was a little bit surprised in that case that normally asymmetric BioRSA is better, even better than the symmetric. And in this case, it was not. So it's important to do not only one type of planification, but to try many planification type to find the best way for your patients. And don't forget one thing. When you do this planification, it's only bony conflicts and bony mobility. You don't have all the soft tissues in the planification. So you have also to manage that in your surgery. And all the things that were said before are true. If you don't do a soft tissue operation, you will have even poor results, even if you have planned well your surgery. In this case, I also think that maybe the type of the glenoid, the B1, which was not so retroverted, is maybe one of the response for the symmetric BioRSA to have better result than the asymmetric one. And maybe we can prefer to use asymmetric BioRSA when we have big glenoid loss, even posterior or posterior inferior. So I'm sorry that because they asked me a little bit late to do this topic, so I don't have the photo of the surgery, but I can show you the results at 6 months for stop. And we can see that this woman have quite good results. She has now a good elevation. She has good rotations, more or less the same or even a little bit better than she had in preoperative clinic. And we have a prosthesis which is lateralized in the glenoid and a little bit lowered on the humerus side. So, if I have to give you some advice, and if you have some things to learn about this topic, is what? Glenoid lateralization seems to be a quite good option to improve the rotation or even to maintain it in people who already have quite good rotations. It avoids scapular notching because the glenoid pillar is more medial than it is with classic prosthesis. It augments also the stability because you have a better strength in the remaining cuff and in the deltoid, and it improves shoulder contour. But is it better to lateralize in the glenoid on the implants or on the bone? I think there is no ideal deal. It's a matter of what you have learned and what you are thinking about. BioRSA is probably for me better biomechanically, and it has been proved. But to be better, it have also to consolidate. And if the graft doesn't heal, you have more constraints on the BioRSA than you have on the implants. And as I said just before, we were talking about this with Jean Canis some days ago, and he is doing implant lateralization, and he don't have so much problem with this type of implants. So now, up to you for the decisions. Thank you.